Okay, so we're going to talk about interspinous decompression fusion spacers, and this specifically is the Minuteman done by the lateral approach. And so we're just going to skip anything. We might take a shot AP. We already have one. We're going to go, let's flip it to the lateral. And we're going to imagine that we have stenosis at 3, 4, and that this is a little bit unstable facet joint gaps. It's got a little bit of spondylolisthesis, and we're going to put a stabilization spacer because the person has neurogenic intermittent claudication and spinal stenosis. Picture that. So notice the cement is at an L4, so the spinous processes slope inferior and posterior. So this is below at 3, 4. The spinous process, the interspace is about right where I'm pointing right there. Can we raise it up a little bit? So we're a little bit challenged about finding the interspace here, but that's okay. We're not going to let that ruin our fun. So we're going to guess that that's just right superior to that. Can you push the eye all the way in? This is a lateral approach. I'm going to make a 2.5 centimeter incision or 1 inch incision right here, and maybe a little bit more just for demonstration purposes. Okay, so we'll start off with the Steinman pin, and you have a little bit more push there. So we'll picture that. That's fine. We'll go ahead and go with it. We're looking for the interspinous space there on the lateral. So I'll drop it down a little bit. Okay, good. So you can start to see that interspinous space a little bit. Picture, and we're going to try to target, picture, between there. Picture that. And it's just posterior to pars interarticularis. Let's see what that looks like. Yep, and that is pretty decently on target. I'm having a hard time really kind of seeing that interspace, so we'll get here and I feel os. So let's go ahead and go back AP, and we'll identify the interspace on the AP view. All right. Pull toward you. Good, so we're a little high, we're a little low rather. So I'm going to just walk it up like this, picture that. And just going to puncture the inner spinous space right there, picture. And so we're going to start off, let's take a lateral view while I get the dilators. And I'm going to hand these over to Joseph. I'm going to put the first dilator in. We're just going to get a lateral view to make sure we're as anterior as possible in this. That's the key, is to have it right up against the anterior portion. You want to put this as close to the spinal laminal junction as possible, and that's perfect. So let's go ahead and come on back around. We're very anterior. And we'll do the rest of our work, at least for a little while, on AP. So you put this in, put this over the Steinman pin, you windshield wiper this on in, and picture that.
So Doug, it's Glenn here, moderating. So for the interspinous spacer you're trying to put in, at this point, you're looking at targeting the 4-5 level or 3-4 level? Just to be clear.
Mostly 4-5. The second most common is 3-4, and then down from there. It's just the levels that most commonly have spinal stenosis. So you get a lot of pressure here, right? Just like that. Get your whole palm of your hand on there. This is going to give you a workout, Joseph. You get your money's worth out of this course. Great. Another dilator. All right. Just really grind that down in there. Twist like this. Mm-hmm. And windshield wiper it down. Picture. Okay, so I'm going to move them a little bit closer. We'll try to get these things as close as we can. Shoot that. And sometimes you can't get them close. I think that's perfectly fine right there. We're going to go to all the way to the first sleeve. Go ahead and place that same way. We're really going to try to shove this in. I'll give you a little counter pressure. So now we're getting into procedures that give you an arm workout. Some of these are predicated on strength, the ability to get that sucker in there. Okay, picture. Good, and we'll, I don't really mind kind of shooting from the back forward. You'd like it just a little bit closer, but on this particular one, it just has a hypertrophic facet, and we're not going to be able to get up and over that. So we're going to pull these inner dilators out, and we're going to show you the rasp. So this medieval torture device is a rasp, so you can place this in over the wire and rasp that facet joint, but because of brevity and just want to keep this as short as possible, I won't use this. I'll go ahead and go on to the graduated tap. And we'll keep that same camera angle, and the graduated tap is conical and threaded, and it has holes. These holes that you can see through here are sizers, 8, 10, 12, 14, and 16. And this thing is fully threaded, and we're going to put an extension on that. We're going to take just a second, and we'll put an extension on the Steinman pin, because it's not quite long enough for that. And then we'll place the graduated tap over the top of that. Perfect. And I'll show you how to, let me just kind of get it started for you. So we want to place this in, and continuous steady pressure. Picture. This is a little bit like placing a wood screw, those of you who are woodworkers. And bone is very much like wood, so continuous, steady pressure. Picture. So it's coming along. Shoot that again. At this point in time, I'm going to turn it over to Joseph. Continuous, steady pressure. Just go ahead and, yeah, there you go. We'll give you some counter pressure. Yeah, for those of you who can't really see this very well, he's leaning into it. Perfect.
More?
Yeah. And let's picture that. And we're making progress. I'm going to turn so the proximal laser marks on this line up with the II. Picture that. And you can see the holes. Let's take it another hole or so. So go ahead and continue steady pressure. Yeah, just like that. Okay. And let's see, where are we? We are, picture, about size 10. So we're going to tell Parker we're going to go ahead and put it at size 10. I'm going to push just a little bit farther in for the purpose of ligamentotaxis. And we're going to leave this thing. And the last thing we do before we take it out is go ahead and load the implant and have everything ready to go. Picture. Yeah, good. So we're past 10. Now we're going to take the handle off, and we're going to dilate up to sleeve 2. So go ahead and put that in. Yeah, perfect.
Doug, is there certain points at which you check out a lateral or things that you look out for?
Yeah, you bet. Because we had that guide pin in the right area in the lateral, we're pretty sure we're in the right spot.
Yeah. But
right here, Glenn, we're going to make sure and take a lateral before we place the implant. So let's go ahead and swing this lateral. And this is the implant itself. This is a 10 millimeter implant. This has wings that come out like this. And these wings can be packed with bone. They can be packed with DBM, DBX, synthetic, and that's right up exactly where we need to be. So we're far enough anterior, and it looks good, 3-4. Nice. And so once we pack it, we'll take the proximal actuator knob down here, and we'll pull it. We'll put these back in place. And now we're going to take out, the last thing we do before we put the implant in is we're going to take the graduated tap out. I'll put the handle back on. And we'll just take it out along with the inner dilator. Shoot that. I just want to get a picture with this in place. And I'm going to get everything started for Joseph here. And then I'm going to have him drive it in. So we'll put the implant in here. The whole thing rotates. Picture. Yeah, so we're going to drive that sucker through and go ahead and push and turn clockwise. Good. Let's picture that. Now we have the extensor plate and the fixed plate. So keep going. We want to get it to the point. Let me see this. This has laser marks for reference. I'll turn it like this. Picture that, Steve. So we can see the little wings that are just past the spinous processes. So in this, you could probably just push this in and deploy the wings. Hit that, so go ahead and hit that with the back of your hand. Picture that. Perfect. And so that's nice and deployed. And now we're going to take this knob too, and we're going to go clockwise like this. Picture. And this is going to bring the two parts, the extension plate and the fixed plate, together. And the winged references are on the side here, and this tells you that the wings are up and down. Before we tighten it, go ahead. Before we tighten it all the way, we're going to make sure that we have the exact trajectory, the bite of the extension plate, the wings on the spinous processes that we want. A lot of turns, Go ahead. Picture that, Steve. Good. So start to get a little bit tight. Let's go ahead and switch lateral. Just hold tight right there. And we have the holder. So we'll go ahead and you can hold it like this as he turns lateral to keep you out of the beam. Just careful, mind my deal right there. So give me a pseudo laterals. That's pretty good. No, that's perfect. Good man. All right, so the wings, you see them on the lateral view. We want them to be kind of up and down. I'm going to turn them a little bit like that. Picture.
So Doug, what are you looking for to make sure you're in position on that lateral?
So pretty much where the wings, it comes out above and below that circle, I'm making sure that they are going to grip onto the spinous process. So we're going to go like this, and I'm going to give it back to Joseph, and he's going to tighten that on down to 3-finger tightness. Okay, looking pretty tight.
Yeah, a little bit more.
Okay. More is always better.
That feels pretty
Except for taxes. So there we go. I mean, that's very nice. And so what we're going to do now is we're going to unscrew this lefty loosey, and it's going to let the implant go. Let's go ahead and unscrew this like that. And it's going to let the implant loose. Go ahead and unscrew a little bit more. Come on. All right. There we go. So the whole thing comes out. Picture that. Lovely. And that looks very good. And let's take a lateral view. And there's a nice lateral view. So 3-4 interspinous decompression spacer, the Minuteman. This particular one was a 10 millimeter. Probably we could have put a 14 in there. It was really more appropriate size. We kind of went with a smaller size for brevity, but that's the whole procedure right there through a 2.5 centimeter incision.
That's a pretty smooth procedure there, Doug.
Thank you. Well done, Joseph.
Nice job. Jesse, do you think that you're going to do a interspinous spacer today in this fashion?
Sorry, Glenn, was that directed toward me?
I was just talking to Jesse. Is he surprised by seeing this type of hardware and dealing with the type of hardware? And this is quite a change over the years that we've seen. A lot more hardware in the interventional pain, interventional spine world, and Doug is just displaying how smooth this can be done, and in a minimally invasive and interventional way. So I think the future is bright for interventional spine, interventional pain. Nice job. Questions for Dr. Beall?
Thank you.
Comments at all?
Have you had to deal with hardware removal, and what does that look like, or hardware failure?
Did you hear that, Doug? Or?
Yes, I've had to take none of these out. I've had to take interspinous spacers out before. And to me, it's easier to take them out from the posterior approach. So I go in just in the back, and I cut all the way down. I usually use a Lexel to get the bone around, because this will cause some fusion. So if anybody's ever taken out a Vertiflex interspinous spacer, even those aren't supposed to fuse, they do often. And there'd be big sheets of bone holding this in. It's like a barbed wire growing into a tree over time. And so this is something that, yeah, you need to be able to take these out. They do have removal kits for these. You can remove it laterally. And so these are made to be put in. They're also made to be taken out. And I think Minuteman Spinal Simplicity has removal kits for Vertiflex spacers as well.
Doug, it's Neil. The patient population that receives this treatment is the spinal stenosis patient with grade 0, grade 1 instability, and often they have fragile bone. Could you comment on the hypertrophy of the facets blocking access and the artful application between spinous processes so that the spinous processes remain?
Yeah, that happens. I mean, the hypertrophic facet, if you get something that really blocks, you break out the rasp. And that's what I didn't use here, but we could have broken out the rasp and sailed right through that posterior portion. That does facilitate fusion of that facet. And then for the interspinous process device, bone strength is incredibly important because you rest this interspinous device on the bone. So if the bone is not strong, it will subside into the spinous process. So I will often treat the patient's underlying bone disorder at the same time I'm putting a spacer in. So that is one of the common things that we do, and we have to be cognizant of that fact. The goal is to get it in place, and these things typically fuse. I'm working on a fusion paper right now. And the fusion rate is 96, 97% between those two numbers. And so it's incredible. It does fuse. People say, I've heard that these don't fuse. That's totally false. They fuse, they fuse, they fuse. It's just if you can get it to fuse in a permanent distraction to where the patient has a permanent benefit before the subsidence happens in weakened bone.
Excellent. Any particular contraindications that the audience should look out for?
Yeah, so pars interarticularis fractures, it takes away the ability to distract. It takes away the biomechanical advantage. Spinous process fractures, angular scoliosis at the incident level more than 15 degrees at the level above, the level below. That's a very prominent arcuate stenosis. There are others that are kind of minor, but those are the major contraindications to this. Did I mention spinous process fracture? But that's the other contraindication. But if you're doing interspinous spacer placement on somebody with a spinous process fracture, we can't be friends anymore. That's just a kind of a no-brainer that you don't do that.
Yeah. Well, excellent. Other questions? A question from our fellow Gavin Nixon. Go ahead, Gavin.
Could you talk a little bit more about when you had to take this hardware out and why?
Yeah, so if this displaces, I've seen one case of something, had a halo around it, and evaluating these I do evaluate it as a radiologist, and so that's not doing any good. That has to come out. Presumably it's an infection. It was an aggressive infection. The other, if it's displaced and is not doing its job, you'll have to take it out and revise it, usually put in pedicle screw and rod augmentation with decompression fusion. That scenario will come out. So most of the time, Gavin, whenever you take these things out, you're going to be doing something bigger anyway. There has to be a reason why you take them out. If somebody has a spinous process fracture, we know from Pierce Nunley's pivotal trial that you just leave it alone. You leave it alone for 6 to 8 weeks and see what happens, because most of these people will become symptomatic after the fracture, and the symptoms will go away. And then after that, you can just leave them alone, and it won't cause any problems. The symptoms will abate, and we'll just leave the spacer in there, leave it alone.
Excellent. Another question. Go ahead.
I have a question. How do you like to close at the end of the case?
So Joseph's question is, how do we close at the end of? So the only cutting here is on the skin. So I don't even do deep closures because it's all fat back there all the way for many centimeters. So I close the subcuticular sutures with 2O Vicryl, Praneo, and Dermabond. That's it.
Nice. Go ahead. Another question here.
One of the principles that are discussed by surgical societies and arthrodesis is a concept of sagittal balance. How often are you putting patients in a Wilson frame to try to address spondylolistheses?
So, a Wilson frame is really great. The downside about Wilson frame, obviously, is the fact that it has gears in the front of it. A lot of my patients have built-in bolsters. I mean, they have lots of stuff up front. And I use a really highly sophisticated positioning device, taped blanket rolls, and I tape them under here and it puts them in flexion, and so it really helps you out. I do find a Jackson table is helpful, and then to put them in the right position and get the right position and not affect their sagittal balance, you can rest assured that you can do up to 2 levels at a time, and it will not affect the sagittal balance of the lumbar spine from the bottom of T12 to the top of S1. That's a lumbar lordotic angle. Will not affect that.
Thanks. Any final questions for Dr. Beall? Yes, one more question there.
I've talked to some of our neurosurgical colleagues, and they kind of say that they would never call this a fusion. What do you say to that?
Yeah, whenever there's bone from one level to the other level contiguous and you can see cortical and cancellous bone, what do you call that? So I think that's, this is one of those things I hear misnomers, Gavin, that they say these things don't fuse. I mean, if you do something radical, like actually look at a CT scan afterwards, and we have the protocol for assessing fusions is essentially the same protocol as assessing interbody fusions. And so, I mean, these fuse and they do pretty well. So the fusion really happens, and all you have to do is look through a series, use your own patients, look through a series of CTs at 6 months, and then you can make the judgment call yourself. And the paper's not yet published that I was referring to. We're not finished with it yet. But that's the fusion rate. It's in the high 90s. So it really does fuse very well. And Formica, not the floor, the doctor, came out with another fusion paper that said it had a 93% fusion rate. That's independent of anything we've done.
Excellent. All right. Well, thanks, Doug. And we'll start moving on to the